Welcome to Mastering Meds. In this video, we'll learn about general approaches for dose adjustment in renal disease.
When kidneys aren't working well, drugs that are cleared by the kidneys stay in the body longer. If you keep giving the normal dose, the drug builds up and can become toxic. So the goal is simple. Change the dose, or how often you give it, so that the average drug level in a kidney patient stays the same as in a healthy person. Think of it like adjusting a recipe. If your oven runs hotter, you either lower the temperature or shorten cooking time to get the same result. Here, we either lower the dose or lengthen the interval between doses.
There are two general approaches by which the dose in renal patients can be adjusted. First, dose adjustment based on drug clearance, and second is dose adjustment based on the elimination rate constant. Before we look at these two approaches in detail, it is important to understand the assumptions on which they are based. Both methods rely on the same set of underlying conditions, and their accuracy depends on how well these assumptions hold true for a given patient.
Key assumptions behind these methods. Before trusting these equations, we assume 1. Creatinine clearance correctly reflects kidney function. 2. The drug's kinetics don't change with dose. 3. Only the kidney route is affected. Metabolism stays normal. 4. Drug absorption is unaffected. 5. Clearance drops linearly with creatinine clearance. 6. Protein binding doesn't change. 7. The target concentration itself doesn't change. Let's move towards the approaches. Approach 1, dose adjustment based on clearance. Let's understand this approach step by step. The main idea is simple. We want the average drug level in the blood, called CAV infinity, to stay the same in both a normal patient and a patient with kidney disease, or uremia. The formula for this average concentration is CAV infinity equals FD0 divided by CLT tau. Here, F is the fraction of drug absorbed, D0 is the dose, CLT is total body clearance, and tau is the time gap between doses.
Now, since we want this concentration to be equal in both normal and uremic patients, we write D0 normal over CLT uremic tau uremic. This simply means the dose divided by clearance and interval should give the same result in both patients.
Now comes the practical part. Case A. If we keep the dosing interval tau the same and just want to find the new dose, we rearrange the equation to get D0 uremic equals D0 normal multiplied by CLT uremic divided by CLT normal. In simple words, the new dose is just the old dose multiplied by the ratio of the patient's clearance to the normal clearance. So if the kidney is clearing the drug at only 50% of the normal rate, we simply give half the usual dose, keeping the same schedule.
Next, case B, which applies to IV infusions. Here, instead of adjusting the dose, we adjust the infusion rate because we want to maintain the same steady state concentration, CSS. The equation is CSS equals R over CLT normal equals R uremic over CLT uremic. This means the new infusion rate, R uremic, is adjusted in the same proportion as the change in clearance. So to summarize, whether it's oral dosing or IV infusion, the underlying logic remains the same. As clearance decreases, the dose or infusion rate should decrease proportionally, so the drug concentration in the body stays safe and effective.
Approach 2, dose adjustment based on the elimination rate constant. Core idea. Instead of using clearance, this method uses K, the elimination rate constant, a measure of how fast the drug leaves the body, as a fraction eliminated per unit time. The equation is as follows. Think of K as a speed, how fast the drug leaves the body. A healthy person's kidney clears the drug quickly, so K is high. A uremic patient's kidney is damaged, so it clears the drug more slowly, meaning K is lower. Example: if a normal person eliminates the drug at 100% speed, but a kidney patient eliminates it at only 60% speed, Ku over Kn equals 0.6, then uremic dose equals normal dose times 0.6. So if the normal dose was 100 milligrams, the uremic patient should get 100 milligrams times 0.6 equals 60 milligrams.
Where does Ku come from? The derivation made simple. Step 1. Total elimination has two parts. The overall elimination rate is just the sum of kidney elimination and non-kidney, mostly liver, elimination. Ku equals KNRU plus KRU, equation 1. And Kn equals non-renal rate constant. Kr equals renal rate constant. Step 2. Define renal clearance. Renal clearance is simply the renal rate constant multiplied by volume of distribution. CLRU equals KRU times VDU, equation 2.
Step 3. Rearrange to isolate KRU. KRU equals CLRU times 1 over VDU, equation 3. Step 4. Apply a key assumption. We assume that non-renal elimination and volume of distribution don't change in kidney disease. KNRU equals KNRN. VDU equals VDN. Step 5. Substitute back into the total elimination equation. Plugging step 4 and equation 3 into 1, substitute the KRU, i.e. EQ3, into EQ1, Ku equals KNR plus CLRU times 1 over VDN.
What this final equation really means? The patient's new overall elimination rate equals their unchanged liver elimination plus whatever renal clearance they still have, converted into rate constant form. So kidney disease doesn't touch the liver's contribution. It only reduces the kidney's contribution. And that's exactly what this final equation captures. We usually cannot measure a patient's renal drug clearance, CLR, directly in the clinic. So instead, we estimate it using something easy to measure, creatinine clearance, which reflects GFR, glomerular filtration rate, basically how well the kidneys are filtering blood. Hope you got the concept. Any doubts, drop it in the comments. Thanks for watching. Keep learning, keep mastering. Only on Mastering Meds.